The first question that I have in front of me is going to be, according to Figo, what is the optimal timing for Maxwell? Now remember, over here the answer is not that important. I mean, in this discussion session that I have, the answer isn't the main thing. The main thing over here is to understand why that is the answer and why the other options not the answer. So that is more important than directly knowing the answer. So the first question is, according to Figo, what is the optimal timing for Maxwell administration for fetal neuroprotection before preterm birth? So this again, I have already made an Instagram and reel basically, and an application reel that I've already made. And it's a very important one because magnesium sulfate is not uniformly given to all the patients who are in preterm labor. A few institutions believe that Maxelf will have its own side effects, and they believe that the effects on the neonate are going to be exclusively and good enough. Action is going to be provided by the steroids that they give. So, just a second. Yeah, an application related out here. So, that is a practice that I completely believe is wrong. So, first of all, what about Maxelf? So, we have already known Maxelf has several actions. There's a reason why Maxelf is preferred in pregnancy, and we do not prefer other drugs like levetiracetam or phenytoin or phenobarbital or any other epileptic drugs. Anti-epileptic drugs are not preferred in pregnancy, and there's a reason. The reason is that Maxelf is going to act on various different receptors, and it includes, for first, adenosine. It potentiates adenosine. The way I remember it is A, B, C, D, E. From A, it is adenosine. Then it potentiates the action of adenosine, which is going to relax the neurons. Apart from that, from B, it is GABA B receptor. GABA B is your inhibitory receptor, which is going to be augmented. It is going to increase the concentrations. It's a neuroinhibitor. GABA is this gamma aminobutyric acid is an inhibitor. Apart from that, you have C, that is calcium. It blocks the calcium channels. D, you have NMDA. NMDA receptors are going to be blocked, and from E it is glutamate. So the last alphabet of glutamate is E. So I take it as glutamate, and it inhibits glutamate. Glutamate is a neuroexcitatory agent. So all these five actions, all in all, are going to cover the major receptors that are causing the neuroexcitability in these women. Now, not just the women, but even in these kids are very much bound. Once those extreme preterm and very preterm babies are born, they are going to be susceptible to a lot of electrolyte imbalances, and those electrolyte imbalances are going to make them much more vulnerable and susceptible to seizures, neonatal seizures. So when I talk about neonatal seizures, I have to remember that every time a fetus, not a fetus, a neonate suffers a seizure, there is hypoxic brain damage that occurs to that baby. I do not want that. I want to completely prevent those seizures, and hence giving magnesium sulfate before birth for at least 4 hours before birth is a very good practice, and for a maximum of 24 hours it should be given. So if you have a baby which has been delivered and is below 32 weeks, now NICE guidelines, ACOG, RCOG have varying parameters. Few say 30, few say 32, but I would like to give the benefit of doubt to the patient, and I would like to stick with the NICE guideline, which says that till 32 weeks of gestation you can give magnesium sulfate to the mother, so that the baby is going to get the protective action, the neuroprotective action after birth. It not just stabilizes that. Remember that these babies have very small vessels. The vessels, the germinal vesicles of the brain, they are very small and fragile. So often after birth, they may rupture, and that rupturing will lead to small hemorrhages, which will trigger seizures. So you cannot prevent the rupture because they are anyway too thin, although you can reduce the chances by giving antenatal corticosteroids. But even after those ruptures have happened, which you couldn't prevent, to prevent the seizure that may happen eventually, this magnesium sulfate is going to play a big role. So it's a very neurostabilizing agent, and hence it should be given at least 4 hours prior to your planned birth. Of course, if the patient is in preterm labor, you can't do anything. But till 32 weeks of gestation, you have to give it at least for 4 hours before birth, and preferably for 24 hours. 24 hours से ज़्यादा देना नहीं है. The action is not that significant. One more question is, what if the patient doesn't deliver in that duration of 24 hours or within the next 7-8 days? Unlike steroids, you are not going to give a rescue course of magnesium sulfate, because magnesium sulfate is also known to displace calcium from its receptors. Basically, it's a calcium blocking agent. It displaces calcium, which is also why in a mother who has magnesium toxicity, we give calcium gluconate. So when you do that, calcium gluconate जब भी तुम देते हो, you have to remember that it is basically again going and sticking to the places where magnesium was settled in the place of calcium. So basically, magnesium takes away calcium from its receptors. When this happens, it leads to something called as osteopenia. So you do not want osteopenia to occur in your fetus. In the mother, there is a lot of calcium, but in the fetus, it can lead to osteopenia, which is why you wouldn't want to give it excessively. Even neonatal respiratory depression can be seen after it is born if you have given it multiple times. So do not do that. Just one single course is enough if the baby is going to be delivered before 32 weeks. So the answer is before 32 weeks, you have to give it for at least 4 hours, maximum of 24 hours. How do you give it? The dose is very similar to Zuspan regimen. You do not call it Zuspan because Zuspan is for eclampsia, but the dose is very similar to that, wherein you will be giving pure IV. There is no intramuscular injection that is given. So you will be first giving 4 grams IV, and uske baad mein, of course 20%, and then uske baad mein you are going to be giving 1 gram per hour के रेट से सलाइन के अंदर मिक्स करके मैग्नीशियम सल्फेट. So that is how you are going to be using Maxil for neuroprotection. Okay. So coming to the next question. Very important question. And with this question, I'm going to be discussing two things. First of all, every single answer. Now, this is I've taken screenshots from our own MCQ book, MCQ application. It is there for all the subscribers. Over there, we are not just giving the answers, we are also giving the explanation. Also, we are revamping a few explanations so that a few questions, when you read them or when you solve them, you will be able to get an entire summary of the chapter so that using tables, using flowcharts, you'll be able to revise the chapter better. So, um, this question, of course, is also we have categorized it for NEET SS के लिए अलग है, PDCT के लिए अलग है, and बाकी INI-SS के लिए भी अलग-अलग questions है. So, which is the safest antipsychotic medication that has to be antipsychotic medication for schizophrenia according to ACOG. So ACOG, RCOG सबका है, there is a consensus. So there are several antipsychotic medications and we get a lot of patients with schizophrenia. And those schizophrenic patients, you have to have a few things in your mind. Remember that all these antipsychotic medications alter your dopamine receptors in your brain, in your central nervous system. So whenever they are altering your central nervous system, you need to know that not just for the mother, but even for the baby, you can end up having neonatal adaptation syndrome. Now, this is a word that you need to remember. The side effect of giving any of these antipsychotic medications can be an excessive, if it is given, can be neonatal adaptation syndrome, wherein the baby is going to be very jittery, the tone is going to be very poor, the feeding is going to be extremely poor, and the baby is going to be having extrapyramidal symptoms like athetosis, chorea, all those things, hemiplegismus, ऐसे जो सब चीजें हैं ना वो सब दिखने वाली है. And it may be difficult for the mother to spot these extrapyramidal symptoms, but one thing that she'll be saying that the baby हाथ में पकड़ते ही ऐसा लगता नहीं वो हाथ में रह रहा है. It feels like the baby is just giving its body away, which is basically poor tone or hypotonia. So all these things very common. You need to remember. So there are a few precautions that you have to take before you prescribe these medications. But before that, you need to know which are the most preferred and the best antipsychotic agents. So the best antipsychotic agent that you can give is going to be haloperidol. This is said to be the best and has the best safety data across all the drugs that we have been giving to the patients. उसके बाद में just making a list over here of all the safe ones. So haloperidol is a safe one. I can preferably give it. उसके बाद में from one of the commonly prescribed drugs, it is going to be chlorpromazine. These are the typical antipsychotics. Apart from the typical ones, in the atypical ones, you can give olanzapine. But olanzapine, by the way, one of my juniors has published, Dr. Saili Sabnis has published an article with me, wherein she has shown, and we have shown, in fact, that there was a patient who was a very lean patient who was not having any high risk factors, but she was having refractory gestational diabetes mellitus. We were keeping her on metformin, the sugars weren't getting controlled. We started her on insulin, the sugars were just not getting controlled. And it didn't look like that female had that body habitus of a very obese female who would be having insulin resistance in the third trimester. Then we realized that one of the drugs that she has been taking for her schizophrenia, pre-conception period से अभी तक ले ही रही थी, was olanzapine. Now, olanzapine and all the second trimester, second generation of the atypical drugs are known to be drugs that increase your insulin resistance or worsen it basically in your pregnancy. So olanzapine is one of them. So one thing that you have to remember is olanzapine, quetiapine, क्वाइटापिन ये तो सुना ही रहेगा। ये सब जो ड्रग्स है, ऑल दी एंटीसाइकोटिक एजेंट्स, यू हैव टू बी डूइंग 24 टू 28 वीक्स के टाइम पे एक ओजीडीटी करना बहुत जरूरी है। एंड अगेन बिटवीन 32 टू 36 वीक्स के बीच में ओजीडीटी करना बहुत जरूरी है, सो दैट यू आर एबल टू डायग्नोज GDM in these patients. It won't go to levels of over diabetes, but it is going to be in the range of gestational diabetes mellitus. So olanzapine is safe, quetiapine is safe, risperidone is also safe. So all these drugs are safe. What are the drugs that you should be avoiding? The drugs that you should be avoiding includes clozapine. क्लोजापिन जो है उसको तो डेफिनेटली अवॉइड करना है। अपार्ट फ्रॉम दैट लिथियम इज समथिंग दैट यू हैव टू अवॉइड इन प्रेगनेंसी। एंड क्लोजापिन की वजह से द बेबीज आर नोन टू गेट नियोनेटल अडेप्टेशन सिंड्रोम, द फर्स्ट सिम्टम दैट आई स्पोक ऑफ, that is occurring because of neonatal adaptation syndrome, wherein the tone is going to be poor feeding. Apart from that, extra pyramidal symptoms, all these things, and of course, respiratory distress as well after birth, are going to be attributed to excessive or overdose of these medications. How to reduce the risk? So, all these drugs, all the safe drugs, इसमें से सब safe ही है except clozapine. Haloperidol is the safest. So whenever you give them, especially during your lactation, I'm saying all this about lactation now. In the pregnancy, you can give definitely, but during lactation, breastfeeding, whenever you give these drugs, the peak action is achieved within 1 to 2 hours. 2 घंटे मान के चलो in the body. Peak action or basically peak concentration in the blood is equivalent to having peak fluid levels or breast milk levels of this drug. So the thing that you have to do is after you take the drug for around 3 hours, the mother should not be breastfeeding. And after 3 hours, the mother can again start breastfeeding. So you have to do a dose spacing for around 3 hours at least, preferably 2 to 3 hours है, 4 hours तक किया तो even better, but 3 hours तो करना ही है between the dose and continuation of breastfeeding. Hence, that is one precaution that you have to take with all the antipsychotic agents to prevent neonatal adaptation syndrome. Did everyone understand this, or does anyone have any doubt? If yes, I'll then proceed to the next question. Is everyone understanding this? Quickly tell me. Any doubts whatsoever at this point? Any doubt? Check who all have joined. Oh, Dr. Nidhi is here. She is my fiance. Hi, Dr. Nidhi. So, yes. Has everyone understood this point, or does anyone have any doubt? I'll then move on to the next question. Please let me know in the chat so that I can get an idea if you all are understanding this session, this question answering. So, oh yes, I just recently got, we had a Roka. So yeah, recently we had Roka, and Dr. Nidhi is the one. She is watching this session. Hi. Hi, Dr. Nidhi. So the next question is, which CNS disorder is most likely to worsen during pregnancy due to hormonal changes? This is a very good question, and something that is misleading in this question or misleading you towards an answer is going to be, what are the hormonal changes that lead to which CNS disorder worsening? Remember that hormonal changes is not going to lead you to an answer. The immunological changes are going to lead you. So how do I know about it? Now, you all have known, if you all have read about the immunological adaptation of pregnancy, your T helper cells from your usual Th1 becomes Th2. So basically the type of T helper cells from in your body from your Th1, which is there in a non-pregnant individual, it becomes Th2 during pregnancy. Now Th2 is classically known to increase my humoral immunity and reduce my cell-mediated immunity. So इसका ये मतलब है that ह्यूमरल इम्यूनिटी बढ़ने से मेरे जो इम्यूनोग्लोबुलिन्स है IgG, IgM, वो सब बढ़ने शुरू होंगे मेरे बॉडी के अंदर. So basically all the autoimmune disorders are going to worsen, which are dependent on humoral immunity, or basically wherein the antibodies are coming and destroying the tissue or the antigen against whom they are binding. So in this, all these diseases that we have, the most important disease that I need to know is going to be myasthenia gravis. In myasthenia gravis, of course, you know that there are antibodies that are formed against the neuromuscular junction, and in pregnancy, these antibodies are going to be formed more because of this immune shift. Because of this immune shift, because there is going to be worsening of the neuromuscular blockade, and hence the symptoms are going to worsen significantly in myasthenia gravis. So the answer here is myasthenia gravis. Why not the others? In multiple sclerosis, this happens to be a T cell mediated or cell mediated basically immunity or immune disorder. So basically, in multiple sclerosis, of course, there is a demyelination that occurs, or all the antibodies that are being formed, or the T cells that are formed are going to go and destroy your myelination of your central and peripheral nervous system. But because it is a cell-mediated immune disorder and not a humoral-mediated disorder, my multiple sclerosis patients are going to have lesser relapses and are going to have a longer duration of remission during my pregnancy. In Parkinson's, it is slightly different. In Parkinson's, you need to know that there are a few things that make a difference. The first thing is that Parkinson's, you have already seen during your MBBS days, is a very drug dependent disorder. That on and off phenomena. Basically, when you give the drug carbidopa, levodopa, जब भी देते हो, there is a significant improvement in the symptoms. The problem with Parkinson's is that, or with many other disorders as well, is that your plasma volume, which increases, basically the hemodilution that occurs during pregnancy, is going to dilute your levels of drug that are present, which is why the action of the drug that you're giving to the patient is not going to last for too long. Also, your renal blood flow is increased, so your GFR is increased in pregnancy, so the renal excretion of drug also increases. The metabolism is basically increased, and hence the effectivity of drug is going to go down. So basically, the you have to step up the drug. So occasionally there is going to be worsening of the symptoms if you are not stepping it up. But unlike myasthenia, where there is a complete worsening of the entire disorder in Parkinson's, stepping up the stepping up the drugs are going to help your symptoms. The next option is epilepsy. Epilepsy is an interesting thing over here. Few patients improve, few patients worsen, whereas few patients stay stagnant. What is this worsening and improvement? Basically, the number of seizures that you get in a certain duration, it is going to increase for a few patients, it is going to reduce for a few patients, and for a few patients, it is going to remain the same. So it is an unpredictable action of pregnancy on epilepsy. The reason is that your estrogen is a pro epilepsy hormone, whereas your progesterone is a relaxing hormone which reduces your seizures, or what we can also call it, increases the seizure threshold so that seizures don't come. But in pregnancy, although progesterone is there in excess, estrogen is also in excess quantity than your normal non-pregnant individual, which is why, because of the rise in both the hormones, although progesterone का rise थोड़ा ज्यादा है, so a lot more patients are going to have lesser episodes of epilepsy, but a few patients are going to have a slight increase. So if I'm going to give you percentages, so in percentages, they say that around 40% patients improve, 30% patients worsen, and 30% patients stay the same. So because it is an unpredictable action, that is not going to be the answer. So the answer over here is going to be myasthenia gravis because of the augmentation of humoral immunity or antibodies that are going to be increased in these patients. Hence, the answer here, myasthenia gravis. Where has this been taken from? By the way, it has been cited from the Cambridge book of obstetric anesthesia. I'd read a summary. I'd taken a handbook of that book. A handbook लिया था उसमें ये concept था, and hence I got to know about this. Although very important for you all to read about immunomodulation during pregnancy. It is given in Williams, so you have to definitely read. It is given in the reproductive changes or physiological changes in pregnancy के immune वाले part में दिया गया है. Now, next question. Before I proceed, does anyone have any doubt whatsoever until now? Any doubts, please let me know in the chat. Does anyone have any doubts? Quickly tell me in the chat so that I know that y'all are having y'all are being coherent with the answers. Okay. So the next question is going to be, which GI disorder does not worsen physiologically during pregnancy? So which of these disorders is not going to worsen? Now, a few things that you need to know about gastrointestinal system. Gastrointestinal system is a very predominantly dependent system on all the sphincters. All the sphincters, it can be your starting with your esophageal sphincter, then your lower esophageal sphincter, then your pylorus, then several other sphincters that are there in your body. Basically, it is all about your smooth muscles that are there in concentration, more concentration in your sphincters. Whereas even in your entire gastrointestinal system, you're going to have several layers of smooth muscles that are forming your intestines, your stomach, your esophagus, everything. Now, progesterone as a hormone is a relaxing hormone and it relaxes all the sphincters and all the muscles. So, whenever there is relaxation, it will lead to an opening of the sphincters or basically reduction in the sphincter tone. Similarly, all the smooth muscles of your gastrointestinal system are also going to be relaxed, and hence that will reduce the rate of peristalsis or the speed of peristalsis. What will this lead to? This will lead to, first of all, your lower esophageal sphincter loses its tone, and hence you are going to have gastroesophageal reflux disease. Basically, acidity is going to increase. Apart from that, in the third trimester, your gravid uterus is going to be pressing upon your stomach and your intestines, and hence the chances of reverse peristalsis and regurgitation are going to be very high. So that is the prime reason that loss of lower esophageal sphincter tone, and also because of your compression by the gravid uterus in the third trimester is going to worsen your GERD. Constipation, as I mentioned, that your peristalsis is going to be relaxed, it is going to be reduced because of progesterone. Your constipation is going to occur in that. Gallstones, we already know that intrahepatic cholestasis of pregnancy is a thing. Even in a normal female who does not, in a normal pregnant patient who does not have IHCP or cholestasis of pregnancy, because of progesterone, the bile ducts, which also, of course, need peristalsis to transport the bile from the liver to the gastrointestinal system, even that is going to get relaxed, which is why there is cholestasis and there is accumulation of bile. Whenever there is accumulation of bile, remember that it will lead to sludge accumulation and gallstone disease. So gallstones are going to be accumulated during pregnancy. A lot of females are going to have their first diagnosis of gallstones in their pregnancy itself. In the third trimester, it is a difficult thing to see on ultrasound, but in the second trimester and first trimester, you may be seeing that. So all these three things are going to worsen definitely. What is not going to be worsening is going to be inflammatory bowel disease. Inflammatory bowel disease happens to be your ulcerative colitis as well as your Crohn's disease. So these are the two things that are not going to worsen. And hence, the answer here is going to be ulcerative colitis. The bigger question here is going to be, what are the drugs that are safe or that can be used for treating ulcerative colitis, and what are the precautions that we should be taking? There is another answer that is coming later on that I think एक और आंसर आएगा आगे जाके, मैं बताता हूँ आगे जाके आएगा. But what are the drugs that can be safely used? Because this is a question, this is a thing that a lot of obstetricians do not know. So all the safe drugs include all the drugs that these patients are anyway receiving, and it includes your 5-ASA, that is sulfasalazine. So the safe drugs for UC and Crohn's disease happen to be sulfasalazine, that is 5-ASA. Then we are also going to be comfortable giving these patients corticosteroids. Apart from that, if I have to give allopurinol, that is also relatively safe, not much of an issue. And जो biologics है, like adalimumab or infliximab, ये जो है anti-TNF drugs, they have to be given only till 24 weeks. Uske baad mein, these can pass or cross the placenta and go to the fetus, hence they are not given. So these are all the safe drugs that can be continued in pregnancy. Just remember that sulfasalazine can have a folate trapping mechanism. Hence, you have to give these patients 5 mg of folate per day, just like you would give for a patient with history of neural tube defect. These patients have to be definitely supplemented with 5 mg per day of folic acid. Otherwise, everything can be given. The drugs that you have to definitely avoid giving are going to be methotrexate, very important, and lastly, tofacitinib. So tofacitinib, poor, and methotrexate definitely you have to stop because methotrexate is going to inhibit your DNA synthesis. If your DNA synthesis itself is going to be inhibited, then you are going to have multiple congenital anomalies that show up, and hence methotrexate, in fact methotrexate stays in your system for around 3 to 6 months. So it is preferable that if you have received methotrexate for any indication, be it for any of these disorders like ulcerative colitis, Crohn's disease, or for rheumatoid arthritis, or if you have received it for ectopic pregnancy, medical management, make sure that you do not conceive for 6 months. A few sources do recommend 3 months, but remember, 3 months is just the cutthroat threshold. 6 months is the safest because it stays in your tissues for at least 3 to 4 months. Hence, avoid pregnancy for that duration. So, ulcerative colitis and Crohn's disease. What do I need to know? So, Crohn's disease, by the way, is known to make ulcers. Several ulcers are being formed in Crohn's disease at various locations. In fact, it is said that various levels, depth of ulcers are found across my entire gastrointestinal system, right from my mouth till my anus. In this scenario, I have to ensure that I am not taking an episiotomy, especially if a female is going to have. There's a question related to this. If a female has perianal Crohn's disease, so if there is any ulceration or any crept that is formed um, in a patient with Crohn's disease near the perianal region, episiotomy is not given. And in fact, because episiotomy cannot be given and you cannot afford to have a perineal tear that goes into the rectum, it is always said that if a female with a perianal Crohn's disease is diagnosed, she is going to be a candidate for elective cesarean section. Always remember this. Perianal Crohn's disease के लिए never give episiotomy. And because episiotomy अगर नहीं दे रहे हो and the baby turns out to be someone who needs a larger space to come out and it causes a perineal tear, I do not want that. To avoid all this, go ahead with a cesarean section. So that is one thing that you need to know for Crohn's disease.